further ado, I will turn it over now to our founder, Dr. Randall Maxey.
Thank you, Dr. Barbara Davis-Stevens, and welcome to our program today. And we're very happy to welcome a previous participant and a very astute physician who is a urologist. Now, I happen to be a nephrologist. I'm the internal medicine side. Dr. Brian Stone is a urologist, which is more the surgical side. I'm going to introduce him, and then we're going to get into his presentation and have some questions. He let me know that he's on call today, so I hope nobody has an acute stone or anything else that will take him out of the way real quick. Dr. Brian Stone is a fellow of the American College of Surgeons. He trained at Morehouse School of Medicine. He got his MD from University of Alabama. He did further training at Albert Einstein School of Medicine in Montefiore. He did a fellowship in neurourology. He'll have to explain what that is. And he also did a work at Columbia University in trauma, part of the trauma team. But most importantly, he has established in Jasper, Alabama, a program that helps bring young men into medicine and potentially surgery. He also served for a while as a surgeon for the New York Police Department, and he just retired from that a few years ago. But the most important thing I want to say, when I had an issue with prostate cancer and had surgery some years ago, he gave me some very personal and useful advice. So I'd like to invite our guest speaker today, Dr. Brian Stone, who's going to talk about prostate cancer. And I added on, how do you survive this after you have it? Dr. Brian Stone, we're very pleased to have you join us today.
Hey, good afternoon, everybody. I want to thank the Black Health Trust and yourself for having me on as a guest again. I did a second fellowship in male sexual dysfunction as well. And I was also on the transplant team at Columbia University, just to throw that in there. Prostate cancer has been very close to me. I've had 4 first-degree relatives, my dad's brother, 2 of my cousins, and another uncle who have had prostate cancer, which puts me at a significantly increased risk than other people. I'm going to cover a few things, and I think one thing that happened in the past 10 years that set us back was the United States Preventative Service Task Force giving the PSA blood test a D grade some years ago, and then subsequently retracting that position and giving it a C grade. So it made things quite confusing and probably put Black men at a greater risk. So I'll talk more about that during the talk. So ready to get going? If you guys, should I pull up my slides, or you're going to do it?
You can do it.
Okay, let me pull up my slides.
We just have them for backup.
Okay. Are you seeing my screen yet?
No.
Okay, let me. Trying to figure out how to share my screen.
There should be a green button at the bottom that has share screen on it.
Are you seeing that now?
Not yet. Oh, there we go.
Okay.
You want to make it a little bit bigger?
I'm doing it right now. How's
There
that?
we go. Perfect.
All right. So we're going to cover a little bit about what the prostate gland is and its significance in the man. And only the man has it, women don't have it. We're going to talk about prostate cancer, symptoms, give you some background statistics, what tests we're doing, and some of the newer processes we're using to increase our ability to detect cancer that's going to be significant versus insignificant cancer. As a patient, what questions are important? Should you be diagnosed with prostate cancer? And then getting a better understanding of treatment options. So the prostate gland is usually the size of I'd say a key lime, a small lime. That's about the average size. It's located beneath the bladder, and the tube that carries urine from the bladder out of the body through the penis passes centrally through the prostate, much like if you put a straw through the center of an apple. The prostate gland is of no real consequence until we turn about 30 years old, and then it begins to grow in size and continues until a man's death. The prostate gland is responsible for creating the fluids that are found in semen. It has the highest concentration of zinc in the male body. We suspect that the presence of zinc serves as an antimicrobial chemical. Some people try to take zinc, but it really doesn't have any impact on the prostate. As the prostate enlarges, it can begin to compress the tube, making it difficult to urinate. This is also known as benign prostatic enlargement, which can't be avoided. It's just a normal process of aging. Most men don't like getting the finger in the rectum, but it's a very important part of the examination because about 80 to 90% of the tumors that grow in the prostate grow in the posterior area that we're able to feel when we put our finger in the rectum. The prostate is not in the rectum, but the posterior side of the prostate pushes against the rectum and is easily felt. Prostate cancer is the most common non-skin malignancy diagnosed in American men. It has a higher incidence in Black men, and it has a higher mortality. It's currently estimated based on current statistics that 288,000 men will be diagnosed with prostate cancer this year, and approximately 34,700 will die this year. 1 in 6 men will have prostate cancer in their lifetime. This risk is heightened for high-risk males, such as men of African descent and men with a strong family history of prostate cancer. But fortunately, if prostate cancer is diagnosed early, before it spreads, you can survive it. And today, about 85% of prostate cancers are diagnosed early. However, whenever they write these statistics, they never really mention the disparity between Black men and the rest of the population. So I think the most important take-home point about risk factors for prostate cancer are that if you have it in your family, you're at about a 6 times greater risk of getting prostate cancer than someone who doesn't. If you are of African descent, you have a much higher risk of getting prostate cancer. There's a lot of talk in the nutraceutical arena about certain herbal medications that can be taken to potentially prevent prostate cancer. That's a myth because we really don't understand the true cause of prostate cancer. Products that contain saw palmetto, Africana pygium, or black root, lycopene and a host of other derivatives are offered and sold, but they really have no proven benefit in preventing prostate cancer. As I stated earlier, Black men have a substantially higher risk of prostate cancer than white men. It's about 2 times the rate seen in the white population. Statistically, in the numbers, it's 232 cases per 100,000 versus 146 for white men. And the death rate is over 2.5 times that of white men at 56 per 100,000 versus 24 deaths per 100,000. Prostate cancer is considered a silent killer. In the early phases, there are no symptoms. When symptoms are felt, it's usually similar to the symptoms that are seen with enlarged prostate: weak force of urinary stream, hesitancy, which is trouble starting, feeling like you don't completely empty your bladder, burning, waking up to urinate at night multiple times, possibly blood in the urine or blood in the semen, pain in the joints and bones, and painful ejaculation. This is really not a diagnosis you can make on your own, and that's why it's important that when you hit the age of 40 that you bring a urologist into your life and start to see a urologist at least once a year. The reason that's important, as a urologist, we deal with this all day, every day. So we are very attuned to what to look for, and we're able to differentiate between benign conditions that affect the prostate and prostate cancer. So the standard test is PSA, which stands for prostate-specific antigen. It is a serine protease. It's an enzyme that is probably involved in the breakdown of semen, liquefaction of semen. Short of that, it doesn't serve any other purpose. It's not produced by any other tissues in the body, but it has been shown to be significantly elevated in prostate cancer. Now, there are some very subtle, some nuances in how to interpret elevations of PSA, and a urologist is very experienced in how to interpret these nuances. Not every elevation of PSA is prostate cancer. As a matter of fact, 60% of PSA elevations are caused by benign conditions. Age comes into play when you're trying to interpret PSA. There's a certain amount of elevation of PSA that is considered allowed for prostatic growth. So your PSA is going to gradually increase over the years as your prostate enlarges. I think it's very important that a man establishes a baseline PSA around the age of 40. I started in my late 30s because of my family history, just so I had like my lowest level so that you can see changes in the PSA. And there's something called PSA velocity, which is the rate of increase of PSA. The allowable increase is 0.75 over a 12-month period. Any increase in PSA over that in 12 months should be considered suspicious. The digital rectal examination is important. I know a lot of primary care physicians and others will only do PSA and avoid the rectal exam. But there are cancers that will not elevate the PSA and may present as a nodule of the prostate. So the rectal exam is still important. A lot of men don't like it. I don't like it, you know, but you do what you got to do to keep yourself safe. So something new that's been incorporated has been a new MRI technology. And I would compare it to a mammogram. The new MRI of the prostate allows us to see abnormalities in the prostate that are suspicious for cancer. The goal has been to reduce unnecessary prostate biopsies. In the past, we saw an elevated PSA and we scheduled a patient for a biopsy, and we were biopsying a lot of cancers, but some of those cancers weren't going to be potentially deadly to the patient. So the goal has been to reduce the number of unnecessary biopsies and the number of cancers that are not going to hurt a person, and try to tease out those cancers that are potentially lethal and need to be treated. So the newer MRI technology has allowed us to do that. So when you get an MRI of your prostate, much like a mammogram, the prostate is going to be looked at by the radiologist, and he's going to give what he sees a certain score. That score is called PIRADS, P-I-R-A-D-S, and it has 5 levels. PIRADS 1 to 2 is usually benign and considered BPH or nothing to worry about. PIRADS 3 is in the middle, and I tend to decide on biopsy based on how high the PSA is and the age of the patient. And then PIRADS 4 and 5 lesions are highly suspicious, and those patients should be biopsied. If you find yourself having a MRI of your prostate, I tell everybody to make sure you get a copy of the MRI on a disc in case you need to get a second opinion at some point in your journey. This just kind of reiterates what I was saying, that the PSA elevation is not always prostate cancer. And so as you see an elevation, some examples, if I have a patient I'm following closely, say 40 to 65 years old, and say last year his PSA was 0.8, he comes to see me 12 months later and his PSA has risen to 1.9 or 2, while that number is not high, that elevation is significant and very suspicious. So I would refer that patient to get an MRI of his prostate, and the MRI would help me decide if I needed to get a biopsy versus going straight to biopsy. The MRI has helped us for those patients who have high PSAs, 8, 9, 10, 15, who've had biopsies that are negative. And even though the biopsy is negative, the patient is scared, the doctor's afraid that, you're afraid you're missing something. The MRI has helped us kind of differentiate people that we need to be concerned about versus those that need additional biopsies. I do something called targeted biopsy, where I'm able to real time in the operating room overlay the MRI image with my ultrasound image and precisely biopsy the area that was seen as abnormal on the MRI. So we've come a long way. This was a study done by Ian Thompson, who's an older urologist. He was in the Air Force. He's based at Lackland Air Force Base in San Antonio. He did a study. It was a autopsy study looking at all decades from 20s all the way up, and they added PSA to it, and they found that even at PSAs of 0 to 0.5, you would find 6.6% prostate cancer. So the prevalence of prostate cancer exists regardless of level of PSA, and it increases as the PSA level goes up. And it also increases with increasing age of the patient. There's been a lot of confusion over the past years about PSA. I think the most significant event was the United States Preventative Services Task Force evaluation of the PSA as a screening tool. What was bothersome to me was that the panel had no urologists, really didn't have any oncologists that dealt with prostate cancer. And they made a decision based on data that was collected in primarily white men on the usefulness of PSA. As a result, there was about a 5-year period where, primary care physicians, the gatekeepers who have enough to do felt like, maybe the PSA, I don't need to get it at, say, 50 or whatever. I can put it off because it's not that important. So during that period, there were a lot of my patients who didn't follow up. And after they reversed their position and gave it the appropriate grade so that it's now covered by insurance, et cetera, we're now seeing patients presenting with significantly elevated PSAs. So this was particularly hurtful for the Black population, where men were already reluctant to get their prostates checked. And it just created further delays and delayed diagnoses. New data from the American Cancer Society has shown a almost 5 to 6% increase in advanced prostate cancer cases in Black men, and that's been attributed to what occurred with this evaluation of PSA. I think it's just very important. I don't think the PSA test is dangerous. I think treatments of prostate cancer are potentially dangerous. So being educated on what the PSA test is, what happens if it's elevated to a level that's considered suspicious, and what would happen after that. As long as a person knows, they can be educated and make educated decisions, the PSA is a very safe test. On the flip side of it, I think it's terrible that you eliminated a patient's choice to know whether or not they had prostate cancer and then allow them to decide if they want to get treated or not. These are some studies that just kind of support PSA. We know that since PSA was introduced around 1995 or so, that overall there's been about a 66% reduction in metastatic prostate cancer at initial diagnosis. So screening had a significant impact on reducing the death rate from prostate cancer and the number of advanced cases. So one group of studies that's always quoted is the European randomized study for the screening of prostate cancer. And their data, they had about 30,000 or so men involved, but there were no Black men. It was less than 1% Black. But even though it was a white population, screening reduced the death rate from prostate cancer by 21% over a 10-year period. So screening definitely is useful. It increases life expectancy, it reduces deaths, and it puts a person in a position to be in control of his destiny. So as a result of the significant disparities in prostate cancer, the group I'm with, R. Frank Jones Urological Society, which is part of the National Medical Association, we felt it was important that we take our own position for our people. And it was kind of at odds with the position of the American Cancer Society and even the American Urological Association. But we really felt that as a result of the higher prevalence and death rate, that PSA testing should begin at an earlier age. And the age that we arrived at was the age of 40. We felt that the harms that were suggested by the task force were overestimated and relate more to the general population and not populations of high-risk men. We recognize that not all prostate cancers require treatment, but we think it's more important that a patient be empowered to make his own decisions. So PSA testing be done. If it's abnormal, the man should strongly consider being biopsied. And at the time that prostate cancer is diagnosed, he should be empowered with and educated to help him make the best decision for him. So our recommendations are initial PSA testing start at 40 years of age, that both the digital rectal examination and PSA be part of the screening process, that patients be educated so they can make informed decision-making, and your assessment on treatment should be based on age, ethnicity, family history, PSA kinetics, etc. So if there are patients listening, I think it's very important that if you're being seen by a urologist who is not incorporating MRI into their evaluation, that you consider finding someone who does. This will kind of reduce the need for an unnecessary biopsy and actually increase the accuracy of the biopsy that you may need to get. So if you're diagnosed with prostate cancer, it's not a death sentence, but it's very important that you understand all of your treatment choices. It's important to have a urologist who communicates. You need somebody who talks to you, who explains everything. And I encourage all of my patients to read. I give them a nice book that's written in easy to understand language about prostate cancer, a couple of pamphlets from the National Cancer Institute to help them become educated. And then we have a follow-up conversation so they can speak from a position of knowledge, and they can ask the appropriate questions. I tell all my patients that I'm not there to tell them exactly what to do. I'm there to be their coach. My goal is not to allow a person to make a bad decision. And so I try to, steer and guide, but not tell them what to do. Surgeons, I'm a surgeon, so I lean toward surgery. Radiation oncologists lean toward radiation. I tell my patients, even if they are dead set on having surgery, that I need them to go and see a radiation oncologist so they can hear his perspective. And then we have a follow-up conversation and go through all the pros and cons of each treatment to arrive at the right decision for that particular person. If you're diagnosed with prostate cancer, one of the first things is, I didn't put a slide on this, but there's something called Gleason scoring. When the pathologist looks at the slide of the cancer, he's going to make a decision about how aggressive the cells are that are in your body. And that's based on Gleason score. Gleason score can go from 2 to 10. The national average Gleason score is 6. The very bad or high-grade cancers tend to be 8 to 10. When you stage the prostate cancer, there are 4 stages. Stage 1 is a limited lesion. Most of the cancers that we find are considered stage T1C using the TNN classification. T1C means there's no nodule or anything. The diagnosis is made based on PSA elevation. Stage 2 would be cancer that's more extensive, involving both lobes of the prostate, but contained to the prostate. Stage 3 would be local extension, either into the seminal vesicles or the surrounding tissue. And stage 4 is when it has spread to the lymph nodes, bones, and other areas of the body. We like to find it in stage 1. So some of the questions I think a patient should ask when they're in the office with their urologist after the diagnosis has been made. Number 1, you want to know, is the cancer localized to the prostate or has it extended outside of the capsule? The prostate has a skin around it, much like an orange peel, that is a natural barrier against cancer or an infection. And it's the barrier that we kind of use in making decisions about stage. You want to know your treatment choices. What are the ways that your particular cancer can be treated? What's the chance of you being cured of your prostate cancer? I don't think prostate cancer is ever cured. Your risk of recurrence is significantly reduced the earlier the stage. Majority of men with very early stage prostate cancer go on to live their entire lives and not die from their cancer. But you should always be monitored because the cancer can come back. You want to know what are the pros and cons of each treatment? Well, what are the side effects? How long will the treatment and the recovery take? If you have side effects, can you expect them right away or will they be later? Will the side effects improve over time or will they get worse? We're all concerned about urination and ability to get an erection. So you might ask, how soon will it be before you get total control of your bladder? Or if you're not going to have total control, what percentage improvement can you expect? How soon can you return to normal sexual function? Or, you know, if you have a problem, what are your treatment options to get your erections back? What can be done if the cancer is spread? Well, what are your treatment options? And then the important question, if you're deciding on who's going to treat you, how many prostate cancer cases have you taken care of and what has been your success rate? So the main treatments that we discuss with patients would be active surveillance, which is not taking action right away, monitoring the patient very closely for signs that the cancer is growing and deciding on what's going to be the trigger for treatment. Surgery, which is the removal of the prostate and the cancer that's in it from the body. Radiation therapy, which involves leaving the prostate in place and trying to kill the cancer cells using forms of radiation treatment. And then there are other treatments that I don't really consider primary treatments for cancer that's been discovered early. But there is hormone therapy that we call androgen deprivation therapy. The prostate is very sensitive to the male hormone testosterone, and testosterone is basically the food for the cancer and makes it grow. Cryotherapy, which I perform, it is freezing the prostate. We get the prostate down to minus 60 degrees, but it's not in my book a primary treatment for a patient who's a first-time diagnosis, who has a first-time diagnosis of prostate cancer. I use it more for salvage for patients who've had radiation therapy and have a prostate cancer recurrence. And then there's chemotherapy for the treatment of stage 4 advanced prostate cancer. So active surveillance in my office, I use MRI, PSA, and digital rectal exam, depending on the age of the person and his Gleason score and how high is PSA. I'll see them every 3 to 6 months, keeping a very close eye. And if the PSA starts trending upward or the MRI changes, we treat. Surgery, I only perform the Da Vinci robotic surgery, which has significantly changed the landscape for removing the prostate. Radiation therapy, I do brachytherapy, which is radioactive seed implants into the prostate in combination with external beam radiation therapy. So when cancer is treated and it's localized, the 5-year survival rate is 100%. If you're found to have metastatic prostate cancer at diagnosis, it's about a 33% 5-year survival. Pros and cons of active surveillance. It's a good choice if you expect to live 10 years and the prostate cancer is a slow growing type. You don't have to deal with any downtime from treatment. You're avoiding the possible side effects of treatment. And there's a possibility that new medical advances may occur during your surveillance period. However, this is the part I emphasize. You are much more likely to die from your prostate cancer within 10 years if you're engaged in active surveillance. Allowing the cancer to just grow may lead to you missing the opportunity to cure it, and it may spread outside of the prostate, because although we're monitoring PSA and we're doing MRIs, we really can't see what's happening on a microscopic level. Repeated biopsies can increase the risk of erectile dysfunction. The older you get, as you age and you're waiting, you may not tolerate certain treatments that would have been available at the time of diagnosis. And about 40% of the cancers that we diagnose and consider low risk are actually growing faster than the grade. So you might on biopsy get a Gleason score of 6, when in actuality in the prostate you have a Gleason 7 or 8. Robotic radical prostatectomy, pros. The Da Vinci robot has changed everything because it's 8 times magnification, so we can see. Blood loss is almost nothing. It allows you to do a much more precise surgery. Recovery is significantly less. I've sent patients home on the same day. Most patients go home the next day. Potency usually returns faster. Incontinence rates are lower and return to normal function with your urination, usually faster within 1 to 3 months. And if you remove the prostate and the cancer returns, you still have all of your options, and it's minimally invasive. The cons, even though this technology has helped us see, there's still risk of erectile dysfunction, which is right around, it would depend on the cancer, but I would say 50-50. You know, a patient may not be completely impotent, but may need to take a pill or do an injection. Very small chance of having major complications. I really haven't seen much in the way of complications, other than some patients with certain heart conditions or severe COPD may have trouble when we inflate the abdomen with CO2, being able to take the anesthesia. And that's about it. Your catheter, you have to have a catheter when you have your prostate removed, but the length of time is usually 5 to 7 days versus the 2 weeks or 3 weeks from the old days. This is a picture of the Da Vinci robot setup. There's not a robot walking around the room during the surgery. It's basically an enhanced version of laparoscopic surgery. The surgeon sits at a console after he connects the robotic arms to the laparoscopic instruments. This slide is on radioactive seed implants. The idea of radioactive seeds evolved from the desire to reduce the side effects associated with the old-fashioned external beam radiation therapy. Radiation hits anything in front and anything behind. So traditional radiation can impact the bladder and the rectum. In the past, people could get burned, and they had something called radiation cystitis and radiation proctitis. So the idea of seeds are the placement of tiny implants. They're about the size of a grain of rice, and they emit radiation in a 5 millimeter radius. So you line them up and place them in the entire prostate. And the idea was that radiation is delivered very focally without extension beyond the prostate. Over time, data showed that patients had better outcomes with the combination of external beam radiation after the seed implant, but the amount of external beam radiation was less. So the pros of radiation therapy, in the appropriately selected patients, there's a chance for cure or good control. You don't have a hospital stay. You have fewer restrictions after treatment. Although after seed implants, there may be a few weeks where you can't hold your pets or your grandchildren in your lap. But the radiation really doesn't last that long. The typical seed we use is radioactive iodine 121. You can also use seeds, radiation therapy, if prostate cancer has spread to other parts of the body. We use it for bone lesions that are painful. Cons of radiation therapy is that at the time of diagnosis, there's no way to predict which patients are going to have a cancer that can grow through or grow after radiation therapy. So patients have a higher risk of death and a higher risk of recurrence than if they have surgery. I usually quote patients, the 10 to 15 year disease-free survival rate for surgery is in the mid-90s, 95%, 92% in appropriately selected patients versus the upper 80s with radiation therapy. And there's no way for us to tell who's going to fail. Radiation therapy will cause fatigue. There's about a 5% chance of radiation proctitis, which is chronic inflammation of the rectum, and radiation cystitis, which is chronic inflammation of the bladder. If you've had radiation, you can't have surgery. In the early days of my career in the 90s, we were doing salvage prostatectomies for patients who had cancer recurrence after radiation, and the complication rate was horrendous. It can be done, but the incontinence rate is very high. This is a slide just showing you kind of the setup for the seed implants. So as you consider your treatment options, active surveillance, I think there are some cases where you might be able to do that indefinitely, but again, it needs to be tailored to the patient. In African-American men, active surveillance has to be very much tailored to the patient. They have to be followed very closely, and the trigger to treat should be, you should be very sensitive, because we already have a high risk of mortality and local extension. And so active surveillance has to be done very thoughtfully in a high-risk male. Surgery, again, the Da Vinci robot has significantly changed the landscape and made it a minimally invasive treatment. A lot of my patients are back to work within 3 to 4 weeks. Cryoablation is freezing the prostate. This is the machine that I use, and I tend to use this more for salvage. It involves inserting these cryoprobes in the prostate, similar to radioactive seed implant. And then we also put a urethral warmer. One of the complications that occurred in the early days of cryofreezing was damage to the urethra and sloughing of the urethra. So we have a warmer where you have continuous warm water flowing through a catheter that keeps the central urethra at body temperature, so there's no ice damage. And we also have thermometers that are inserted between the rectum to let us know how cold it's getting, to avoid the risk of a fistula, which is a hole between the rectum and the prostate. But cryo has come a long way, and it's actually very safe. A lot of people have heard about the CyberKnife. Basically, it's robotic radiation therapy. It is a way to more precisely deliver radiation to the prostate and limit the amount of radiation to the surrounding tissues. But there's still a risk of injury to the rectum and bladder. You've also probably heard of proton radiation. It's radiation therapy using a different type of radiation delivery. It still has the same risk. It's a very, very expensive way to deliver radiation, and you probably won't find those outside of a university setting. So if you're diagnosed with prostate cancer, I think it's very important that you understand your treatment options and you get detailed information about risk and benefits of each treatment. As you understand these things, it can kind of help you in making your decisions. Decisions on treatment will be very nuanced based on your age, how healthy you are, what other surgeries you've had, or what other comorbidities you may have. And these decisions can be made with the help of your urologist. Surgery come a long way. The robot has changed. The landscape is definitely not as bad as it used to be. Patients do quite well. Radioactive seed implant is a great option, but patient selection is very important because once you've had radiation, it's very difficult to have surgery. So you want to try to make the best decision up front. A lot of patients base their decisions on what happened to a friend or what they've heard about. You just have to remember that everybody is different. I can perform the same treatment with 10 different people and possibly get 10 different outcomes. Teamwork, working with your physician and reviewing information and making a decision is the best way to move forward. Don't be afraid to get second opinions. I think the future is bright in prostate cancer, particularly with genomic research. I'm involved with a program that we've been working on for 10 or 15 years. We finally, when I say we, I'm speaking of a group of Black urologists. We've decided that if the system is not going to provide the answers that we need, we're going to have to get the answers ourselves. And we've created something called the Conduct Prostate Cancer Registry Trial. The Conduct team has set this trial up at Clark Atlanta University. We thought it was very important that it be at a historic Black university. The goal is to create the largest database of Black men with prostate cancer in the world. On our executive team, besides myself, we have Dr. Walter Rayford, Dr. Bud Burnett, who's a professor of urology at Johns Hopkins University. We have Dr. Curtis Pettaway, who's a professor of urology at MD Anderson. We have Dr. Jean Joseph, who's a professor of urology at Rochester University. So we have a host of guys I've been working with for about 30 years. And we now have got the attention of the National Cancer Institute and the NIH, the American Cancer Society, and the City of Hope. And we are very close. We've actually started the registry trial, but we're about to get a large amount of funding to move us toward our ultimate goal of having a tissue repository so we can begin to collect tissue from Black men and do genomic studies in a way that can be trusted and the data controlled by physicians of color. So I'm going to end my talk there and open the floor to questions.
Dr. Stone, I thank you. That was an extensive, excellent talk. I learned a lot and have a lot of questions. I'm sure we have questions in our chat, but let me first go to our co-moderators, Dr. Neighbor Stevens and Dr. Walks, and then I have a question after they start.
Okay.
So Dr. Stone, thank you for giving us a very helpful background of information and decision-making tools about prostate cancer. But what else should a man worry about in terms of their prostate?
So something I see a lot, because the prostate enlarges and it kind of gradually begins to block the flow of urine, a lot of men ignore the symptoms of an enlarged prostate, which has nothing to do with cancer, but can lead to significant issues with the upper urinary tract. And when I say upper urinary tract, I mean kidneys. As the prostate occludes the flow of urine, it begins to elevate the pressure in the bladder. The valves that protect the kidneys from urine and pressure backflow are designed to handle pressures up to 40 centimeters of mercury. 40 centimeters of water. And for lay people, I just say 40 millimeters of mercury because that's what we're used to hearing. Pressures can exceed that and reach in the hundreds, and sustained pressures can lead to upper tract damage. In the older days, men would die from kidney failure as a result of an enlarged prostate. So if you find yourself waking up at night more than twice, if you find that the urgency to urinate has become very severe and you're having maybe episodes where you pee on yourself before you can reach the bathroom, the flow begins to get extremely weak, you're having to strain to urinate. These are all signs of enlarged prostate. And instead of ignoring the problem, you need to seek treatment with a urologist before the damage becomes irreversible.
Thank you. Dr. Walks?
First of all, let me stop being terrified. Dr. Stone, it's good to see you again, and thank you so much, man, for all that information. It is scary to hear. It is. We don't like to think about things like this, especially in that part of our body. That's just a man thing. And I think that experts such as yourself sharing that with us is just so important. A couple of things from the chat that I think are absolutely reasonable questions. One, is there a baseline PSA for African-American men that's different for other groups of men? Or is it just a matter of some of the other health inequities that we seem to have more trouble with later diagnosis and mortality? And then a part of that concern also is, if a man has a vasectomy, is that in any way related to his risk of prostate cancer or prostate problems?
Okay. So there were some attempts to come up with ways to use PSA based on age. Like we came up with different levels based on each decade, which I think is somewhat useful. I would say more so than race, the age is the one that should be used. And from say 40 to 49 years old, your PSA should be under 2, which at times 2 can be kind of high. From 50 to 59 up to 3. And then from 60 on up, I'd say less than 3.5. But we found that the absolute number is less important than knowing a baseline PSA from which you can compare a new PSA to, because the rate of increase is much more concerning than the number sometimes. So establishing a PSA as a high-risk man at the age of 40 or late 30s is of the utmost importance. It's like knowing your blood pressure. So I recommend, even if your doctor tells you that the PSA isn't that important, you can wait till you're 45, you can wait till 50. I would insist that you get a PSA as part of your routine annual examination, and that you know that number. Because if that number changes, I see a lot, the primary care physicians, I'm not saying they're bad or anything, but they have a lot of things they got to worry about. They're worrying about your lungs, your heart, your blood sugar, your thyroid, you know, you getting your colonoscopy, blah, blah, blah. So PSA, as far as really being precise with it, that's not high on their list of things. So it's important for you to insist that it be done, and your insurance will pay for it at least once a year. So I hope that answers your question. And as far as you had one last question about vasectomy. Multiple studies have shown there's no connection between prostate cancer and vasectomy. That myth came out in the 90s from a very old study, but that's been disproven. There's no connection.
Thank you so much, Dr. Stone.
Yeah, I've got several questions. The first one being, if a young man in his late 20s has a strong family history, grandfather, father, uncles, and brothers, would he get his PSA and digital rectal early by your recommendation? That's one. And number two, in your study, what type of man are you recruiting for the study? We have several people, for example, on this call who've had previous bouts of prostate cancer and various forms of treatment. And then is there any, when do you recommend men consider prosthetic treatment? Okay.
First question, 20s is still very young. The youngest man, I mean, I can't say that a significant prostate cancer can't happen that early. I haven't seen it. The youngest I've seen is 30s. So for me, I felt it was reasonable for me to start at the age of 37, getting baseline PSAs. So I think a 20-year-old man with a strong family history could wait until his 30s and get a baseline PSA. And unless there was something wrong, I don't think that's something that needs to be checked every year until they get closer to 40. But I think it's important, if you got a strong family history, that you establish a baseline PSA, I'd say by the age of 35. Now, that's not written anywhere. This is just my personal experience, because I was highly concerned about my own risk. As far as prosthetics, with erectile dysfunction, it's important to go through the progression of treatment. So you do the pills. If the pills don't work, I do a Doppler study on the penis. So we basically checking the blood flow, and then based on that, coming out with, say, an injection treatment where you can inject medicine directly into the penis, which is another option when the PSA, not PSA, but when the pills don't work. And then when all the medical options have failed, the penile prosthesis is on the table. Penile prosthetics have evolved tremendously since the 70s. I've implanted over 3,000. The pump, the durability, infection rate, everything has significantly improved. The infection rate is less than 2% in the hands of somebody who does a lot of them. Mechanical malfunction rate is probably right around 2%. And there's some new treatments on the horizon. there's something called, it's like a shockwave treatment that's designed just for the penis. It's called core wave therapy. And in certain cases, early prostate, not prostate, but early erectile dysfunction, you can deliver shocks that stimulate the ingrowth of new blood flow. And you can take a man from pills to nothing, or a man who's using injections back to pills. And we're also doing something called plasma-rich platelet therapy, where you take a man's blood, spin it down, and take the serum part and re-inject it into the penis, because there are some stem cells there that may promote ingrowth of new vessels. So these are very new treatments that are available, but patient selection is very important.
Just to clear up, the shockwave therapy, that's mechanical shock, not electric shock, correct?
Yeah, mechanical. It's the same technology we use to break up stones, but it's been reduced into a handheld version for the penis.
All right. Well, very, very good. Are there any questions in the chat, Dr. Wilkes?
There are a few questions in the chat, Dr. Maxey. The questions I raised earlier were from Tony Wofford, who also would like some information about getting involved with the study. As you mentioned earlier, Dr. Maxey, we do have a variety of folks who are part of our Black Health Trust family, and certainly Tony Wofford is one that is very actively interested in being supportive.
So as far as the conduct study, we have a website, CONDUC, and it's the consortium on urologic diseases. So we're easy to find, and I can send a link that you guys can post with your group.
Thank you so much, Dr. Stone. Two other things quickly, Dr. Maxey. One, there was a question about whether the slides would be available or sent out to the participants. And I just want to remind folks that the Black Health Trust programs are archived, and folks can get to them that way. We're also on YouTube, and you can pull up a program that way. One of our most faithful attendees, Dr. Ken Steiner, had a question about how does sexual activity affect the frequency of prostate cancer?
There's no relationship between sexual activity. There was a study that showed that if you check PSA the day after sex, the ejaculation might make the PSA elevate, and it's a mild elevation, but there's no relationship. Have as much sex as you can.
So bike riding and football and all those things can elevate PSA temporarily?
No, bike riding has been linked with infertility and erections, but it's erectile dysfunction more related to the narrow bicycle seats and the passage of the pudendal arteries in that area where you sit. So professional bike riders, sorry about that. Professional bike riders are at a higher risk of this than just regular people.
Can I ask one other question, Dr. Maxey? Sure. Dr. Stone, I was thinking as you were giving this really wonderful presentation that what we've begun to see over the last several years with women and breast cancer is the early mastectomy before anything can happen. I've got no symptoms, I've got nothing going on, but I've got a strong family history, sisters, mom, etc. And so they're going in for the mastectomy. Is that something that we're seeing in men where they say, you know what, if I go get the prostate taken out early? Can you just speak briefly about, does that make any sense?
No sense at all, because the risk associated with a mastectomy is limited, maybe cosmetic. With prostate, because of its location and the risk of, you got the rectum there, so you could potentially injure the rectum. You could get erectile dysfunction from damaging the nerves. You could leave a patient incontinent of urine. The only time that risk should be taken is in a situation where prostate cancer is present. Now, we do perform simple prostatectomies for men with massive prostates, and we have a bunch of those, and we do it robotically. This involves coring out the center of the prostate, leaving the shell in place, which limits the risk of, incontinence risk or erectile dysfunction. So that's about the only time where we will surgically go in and remove the inside of the prostate when it's not prostate cancer.
This has
Thank
been
you so much.
A very educational afternoon. And like Dr. Walks, I sat here cringing during some of the descriptions you were giving.
Look, I have enlarged prostate and I got issues, and there's a new treatment for BPH that I perform. It's called UroLift implants. It would be high on my list. There are these small titanium implants that you can pop into the prostate and tighten and pull the prostate open. It doesn't involve removing any tissue. It's very effective, and it doesn't interfere with if you need to have the laser surgery that we do down the road. But it's a very easy treatment. It takes 15 minutes. You don't need a catheter. So for any of you with enlarged prostate, look up UroLift, UROLIFT. That would be my first choice if my prostate size is appropriate.
Yeah. I'm going to see
Dr. Maxey, let me ask one other question. I know we are over time, but Dr. Stone, one of the things that was in the chat earlier from Tony Wofford, and it's really a big deal for us here at Black Health Trust, and I'm sure for you. Dr. Maxey and I both talked about cringing during parts of the presentation, and we don't want to talk about this. We don't want to talk about anybody doing anything in that area of our body, period, end of story. So how do we normalize this? How do we get people to understand it's a part of our regular taking care of ourselves, being responsible to our families? What are the efforts that you and your group have done in this area to just make it an ordinary conversation in our community?
Yeah, I think men should learn from women. Women normalize the conversation about breast cancer, and it had a significant impact on how they deal with breasts. They talk about it, they publish it. Issues with breastfeeding, and the public was all uptight about it. Now, because it's been promoted, it's been shown, it's been talked about, it's accepted, and it's normalized. In male publications, we don't really talk about this. So we got to talk about it. We got to have lectures like this one. We got to promote it in magazines. We got to every opportunity to talk about it. We need to talk about it, get people comfortable with conversations. Dads need to talk to their sons. My family, we have family gatherings. The women might talk about health issues. The men didn't talk about anything but sports and comfortable topics. They never talked about, I didn't even know about prostate cancer in my family until I was a urologist, and one person needed some advice. So we got to talk about it. It needs to be part of the family conversation, at the table, at holidays, etc. And I think that's how we become more comfortable.
I noticed, Dr. Neighbor-Stevens, I'm going to ask if I can have 30 more seconds just to ask one last question before we go. I noticed Dr. Alice Coombs, who used to be the president of the New England Medical Society some years ago. She's now chair of anesthesia in Virginia. But there are a lot of concerns that men have, not only about prostate cancer, but about men's health in general. And the point that you bring about, we should imitate women, that they're so public about breast cancer and those things. But women have a lot to say about what the man does. And we propose that women lead the fight to get men to take care of men's health. I wonder if you'd comment on that a moment.
So I can give you my personal experience. I started a prostate cancer screening program in New York City, in the Bronx, for Black men. And the initial program I tried to do using the deacons in the church. I did it in the church. We did it with the men's group. Participation was low. So I had one of the wives come to me and say, Dr. Stone, you need to promote this to the entire congregation and do this in a way that the women can be involved. So I changed the model to doing a lecture to the congregation with screening immediately after church service. And we went to maximum participation, ended up screening 5,000 Black men over a period of about 8 years. So the wives being involved has a significant impact on a man's behavior, 100%.
So thank you so much. So any final words before we go to the end of our program, Dr. Stone?
I just think, this is a great platform, and the more we talk about it, the more comfortable people will be. And technology has improved, diagnostic capabilities have improved. And the one issue we have to address is the underrepresentation of Blacks in clinical trials. As medicine moves toward precision medicine, where treatment is based on your genetic makeup, we are going to have to be involved in order to benefit, or else we're going to be left out again. The white people are going to end up getting the best treatment because they're participating and we're not.
Well, thank you so much. And make sure you put the information on that website in the chat if you can.
Yes.
Dr. Ivan Walks.
Again, Dr. Stone, thank you, brother. It's good to see you again. And
hey, man, always a pleasure.
And it's good to get the knowledge. We really are blessed to have you be able to share with us. I just think, Dr. Maxey, one of the things that we talk about a lot on Black Health Trust, and I just like to reiterate it all the time, our entire body walks around with us. And we need to be as healthy as we can every day, because there's always something out there that's coming to get us. So the diet, the exercise, the sleep, the checkups, the screenings, all of those things matter so much, not just waiting until something is hurting or something fell off.
Well, thank you. Dr. Barbara Neighbor-Stevens.
Thank you again, Dr. Stone, and rest assured, we will be inviting you back.
I'm always available.
Good to know, good to know. We are trying our best to empower our community with information. So I want our audience to expect continuing sessions like this, where we review what we can do to keep ourselves healthy.
Well, thank you so much. Simon, do you see Dr. Tony Brown on the line? Dr. Tony Brown is a physician. He also has a PhD. He's at Harvard Medical School. He also lives in New Hampshire, Dr. Steiner. And he's on the side of an 8-acre lake. But he's going to be our speaker next week, speaking about brain health and ways to intervene in people who have had or are at risk for strokes. And we're looking forward to his joining us next week for a very interesting discussion. I see Dr. Gary Dennis on the line, who's our famous neurosurgeon. And thanks everybody for attending our session today. Simon, thank you for your help. And everybody have a great, great remainder of your Sunday afternoon.
Thank you.
Good day, everyone.
Bye, everyone.
Bye-bye.